The topic of my abstract was phase 3 study of durvalumab in patients with locally in patients with resected stage 2 or 3 NSCLC who become MRD positive after curative intent therapy. Starting with the background, in patients with resected stage 2 or 3 NSCLC, the 5-year disease-free survival rate with standard of care adjuvant chemotherapy is just 40%. Despite advances with immunotherapy in metastatic setting, overall survival rates for patients with recurrence remain low. So before coming to our present study, I would like to revise the two previous study done with durvalumab. So first is a Pacific study. This was a randomized phase 3 double-blind placebo-controlled trial in adult patients with locally advanced unresectable stage 3 NSCLC with more than 2 cycles of platinum-based chemotherapy. The patient were randomized between durvalumab and placebo in 2:1 fashion until disease progression or unacceptable toxicity. The primary endpoint was PFS and secondary endpoint was overall response rate. In this study, we found that the overall survival was better in durvalumab arm. The same was true with progression-free survival and time to distant metastasis. So the consolidation durvalumab improved survival outcome in patients with unresected stage 3 NSCLC without detectable disease progression after curative intent chemoradiotherapy. Again, the second paper which I like to highlight is circulating tumor DNA dynamics predict benefit from consolidation immunotherapy in locally advanced non-small cell lung cancer. This study was published in Nature Cancer in 2020 by Moding et al. So they showed that the freedom from progression 24 months after starting chemoradiotherapy was 0% in patients with detectable circulating DNA compared with 100% in patients with undetectable circulating DNA. The majority of patients in their study consolidation immune checkpoint inhibitor cohort had undetectable circulating DNA after chemoradiotherapy. The outcome of these patients were excellent and the 1 year freedom from progression of 80%. So this is the graph in which it has been shown that those who have detectable circulating DNA has better prognosis as compared to those who have undetectable circulating DNA. Also, they found that in those patients who have not received immune checkpoint inhibitor and doesn't have circulating DNA, those prognosis was as good as those who have received consolidation immune checkpoint inhibitors, showing that the MRD can predict those patients who are going to benefit from immune checkpoint inhibitor. Again, those who have circulating DNA detected post chemoradiotherapy and who have received immune checkpoint inhibitors had better survival as compared to those who have not received consolidation immune checkpoint inhibitors. Also, they shown that those who have circulating DNA decreasing trend with consolidation ICI have better prognosis as compared to those who have non-decreasing circulating DNA. Also, this was true for freedom from distant progression also. They also showed that those who have increasing circulating DNA on consolidation ICI showing the primary resistance to immunotherapy. So these patients have poor prognosis, same as those who have not received immune checkpoint inhibitors. So the conclusion of this study was that circulating DNA monitoring after chemoradiotherapy and early during consolidation immune checkpoint inhibitor could identify the subset of patients who would mostly benefit from consolidation immune checkpoint inhibitor. Consolidation immune checkpoint inhibitor appears to improve outcome in a subset of patients with MRD following chemoradiotherapy for locally advanced NSCLC. Patients without MRD after CRT appear to have excellent outcome irrespective of consolidation immune checkpoint inhibitor treatment, and rising circulating DNA during consolidation immune checkpoint appears to strongly predict the risk of future disease progression. So on the basis of this study was designed for resected stage 2 or 3 NSCLC who have completed their curative intent therapy and who have been detected MRD positive during surveillance with no disease recurrence visible on imaging. So these patients were randomized in 1:1 fashion between durvalumab and placebo. Durvalumab was given at a dose of 1500 mg IV 4 weekly up to 24 months, and they were followed up until disease progression or unacceptable toxicity. The primary endpoint of this study is disease-free, progression-free survival in patients with PD-L1 tumor expression more than 1%. And the secondary endpoint of this study is disease-free survival in full analysis set, progression-free survival, overall survival, time to subsequent therapy, patient-reported outcomes, and safety. So this is the flow chart. Histologically confirmed EGFR ALK wild type stage 2 or 3 NSCLC who have completed curative intent therapy enrolled in a 96-week surveillance period. They are going to be monitored regularly for MRD emergence via circulating DNA analysis or plasma sample. Those who come MRD positive are going to be randomized between placebo and durvalumab. And these are the primary and secondary endpoint. Thank you.